Hello and welcome to my talk on COVID-19. I'm Dr. Syed Raza and I work as a cardiologist and physician at Awali Hospital in Bahrain. In the next 15 minutes or so, I'm going to give you an overview as to how heart is involved in COVID-19. I'm going to shed some light on its pathophysiology and then briefly discuss its management strategy from cardiovascular point of view and then finish with some key learning points. These were the early days when coronavirus was born in Wuhan, China, and then it spread rapidly to different countries of the world and causing a full-blown corona or COVID-19 pandemic. It was soon being recognized that lung was bearing the majority of the brunt of this COVID-19. But it was also soon understood that heart indeed was in the heart of this COVID-19 crisis. These were some of the small studies that came out of small trials, again from China, that showed a distinct but definite link of COVID-19 with the heart. Large-scale epidemiological studies showed that the patients who had underlying cardiovascular disease indeed had higher mortality. And as you can see here, the figures were certainly high. 10.5% was the mortality in patients who had underlying cardiovascular disease compared to 0.9% who did not have any underlying cardiovascular disease. So that essentially shows the high scale of a problem that patients having underlying cardiovascular disease had a much higher risk of dying from COVID-19. This was further confirmed with data from WHO that showed a similar trend. And as you can see here, patients who had higher who had cardiovascular disease had higher mortality. Now, this was an important observation that was made in 4 provinces in Lombardy in Italy. And what it essentially shows, and if I can draw your attention to the top panel, and if you can follow the red line. So red line essentially shows the increasing number of COVID-19 cases in these 4 provinces in Lombardy in Italy from February 20th till the end of March. And this again shows, as you can see on the blue bar, these are the out of hospital cardiac arrests. And this again shows that there was a link of COVID-19 with underlying cardiovascular disease. Now, the pathophysiology as to how heart is involved in COVID-19 is not only complex, but it is also multifactorial. Primarily, the heart can be involved in 3 different ways. And the 3 different ways are there can be hypoxic injury, and the heart can be involved by a systemic inflammation, and it can also be involved by direct attack of virus on the cardiac muscle. Now, the commonest way the heart is involved is by hypoxic injury. Now, we all know by now that the lung is the major organ that is affected in COVID-19. And when there's lung involvement, there's pneumonia, and that can eventually lead to ARDS. And both these conditions, they can cause significant hypoxia. And this hypoxia can in turn lead to significant cardiac injury, or what we call the hypoxic cardiac injury. Now, we all know that COVID-19 is a systemic inflammatory condition. There are a lot of inflammatory markers that are floating around in the systemic circulation that can bring about a cardiovascular instability, causing severe hypotension, and also lead to cardiogenic shock. Now, this is the second way as to how heart can be involved, because if there is cardiogenic shock, there is again ischemic injury to the heart muscle. The third, but the least commonest way as to how heart is involved is by direct attack of virus on the heart muscle itself, leading to inflammation of the heart muscle or the myocardium, and what we call is myocarditis. Now, just to show you again the pathophysiology of the COVID-19 as to how heart is involved. Now, As I have mentioned that COVID-19 is a systemic hyperinflammatory condition, and this can also sometimes lead to rupture of the atherosclerotic plaque, which is vulnerable plaque on top of the atheroma. And once this plaque ruptures, it releases the atheroma within the atherosclerotic plaque that can occlude the coronary lumen, and that can lead to acute coronary syndrome, which includes ST segment elevated MI and non-ST segment elevated MI. Systemic hyperinflammation also accelerates the thrombotic activity, and this will lead to thrombus formation. And the thrombus is formed not only in the small blood vessels, but also in the major or blood vessels, including the coronary arteries. And once these coronary arteries are occluded or thrombosed, this can again lead to acute coronary syndrome-like picture. So what is myocardial injury? So myocardial injury must include the three features. So you would expect rise in the cardiac biomarkers, which include troponin and also BNP and proBNP. You will expect to see some changes on the ECG, and this may be in the form of T wave changes, or they may also be ST segment depression, and rarely they can also be ST segment elevation. When it comes to echocardiogram, you will expect to see some wall motion abnormalities. Now, these wall motion abnormalities may be a regional wall motion abnormality, which will suggest there's involvement of the coronary arteries, or it could be a global wall motion abnormality suggesting a myocarditis mainly. Now, this is a slide that has been devised by myself. You're not going to find in any textbook or any web page. Now, this is essentially to show as to how we can distinguish the two presentations in COVID-19, myocarditis and infarction. Now, people who work on in acute coronary setting would recognize that troponin sometimes confuses everybody, and we cardiologists are consulted on the troponin rise, what we call tropinitis. So we are sometimes not sure as to why the troponin is high. Is it something as, due to some underlying infection or systemic inflammatory process, or there is an acute coronary syndrome or myocarditis? Now, the top two differential diagnoses you've got to keep in mind is myocarditis and myocardial infarction. And this is because both can have higher mortality. At the same time, these two conditions are managed very differently from each other. Now, if you ask me as to what is the definitive investigation to confirm a diagnosis of myocarditis, then it is endomyocardial biopsy. And a definitive diagnosis for acute coronary syndrome will be catheter coronary angiogram. Now remember that these two investigations will not only be difficult, but it is going to be almost impossible for patients who are lying on coronary care unit beds or intensive care unit beds. They are very, very sick to conduct these kind of investigations. You may rely on the investigation on other modalities of cardiovascular imaging, cardiac CT or cardiac MRI. And as you can see here, the right hand panel, the moving picture is of cardiac MRI of myocarditis. And if I can draw your attention here, if I'm moving my cursor, you'll see a white line here. This is essentially a late gadolinium enhancement, and this is typically seen in the mid wall of the myocardium. So myocardium is in all gray, and the white thing that you see in the middle is late gadolinium enhancement. And this is quite typical of myocarditis. Sometimes it is also seen epicardially. So epicardially and mid wall is very typical of myocarditis on cardiac MRI. And if you can see on the left-hand panel, this is usually subendocardial. This late gadolinium enhancement is subendocardial in myocardial infarction. Now, obviously, these investigations are a little difficult to get in sick patients. So what you are really going to rely is on your basics. And basics is the initial clinical evaluation of these patients, and at the same time, using your own sound clinical judgment. So I think that's again very, very important to keep in mind that these basic skills should be kept in mind in reaching a diagnosis in these COVID-19 patients. Now, you all know by now that we all say that COVID-19 affects mainly in a severe way. I mean, the elderly or the patients who are above the age of 60 or 65, and if they have underlying comorbidities like hypertension, diabetes, if they're obese with high BMI, and so on. Now, soon it was also being recognized that young patients, children, and young adults were having severe form of COVID-19, and they were not only having severe COVID-19, but they were also dying suddenly. So this raised a question as to why, first of all, these young adults and healthy individuals were having COVID-19, severe form of COVID-19, and they were also dying suddenly. Now, if I can draw your attention on this slide, if you see on the left-hand panel, there's a list of what could be the possible causes. Now, this list is again devised by myself, having read through the literature on this subject. Now, the young individuals may die suddenly because primarily of two, three reasons. One is the acute fulminant myocarditis, which is a condition where the heart is severely and suddenly inflamed within a few days, and that leads to acute cardiac decompensation, acute heart failure, and this acute myocarditis also leads to malignant arrhythmia like ventricular tachycardia and ventricular fibrillation, and that can lead to sudden death of these individuals. Systemic inflammation, as I've mentioned, it stimulates and accelerates the thrombotic activity within the cardiac circulation, and that would indeed lead to a prothrombotic state, leading to coronary thrombosis and acute coronary syndrome or acute coronary syndrome-like picture. There can also be thrombosis in the cerebrovascular circulation, leading to ischemic stroke, and sometimes these ischemic strokes can be large and they can be fatal and can lead to death of these young individuals. There can also be thrombosis in the pulmonary circulation, leading to acute pulmonary embolism. So these conditions are really severe or serious conditions, and they may actually kill the young and healthy individuals. But remember, again, this is not very common. This has come as some case reports, and this is again rare. But it is important to bear in mind that yes, young patients are not immune to COVID-19. A concern was raised as to how COVID-19 can increase the severity of the disease in patients or people who are taking drugs like ACE inhibitors and angiotensin 2 receptor blockers. Now, ACE inhibitors and angiotensin 2 receptor blockers, you all know, or some of you may know, that this is a very common drug that is given to hypertensive patients. Patients who have heart failure or chronic kidney disease are also on these medications. Now, so what was the concern? The concern was that these medications can increase the severity of COVID-19 disease. I started to receive calls, and some of my colleagues started to receive calls from patients, and they were very concerned as to whether they should continue with these medications or they should stop. Now, we did not have much information, so we did not have a very clear reply, but soon it came to light that this was safe. So let me explain on this slide as to how ACE is involved and what is the role of ACE in COVID-19 disease. So on the left-hand panel, as you can see here, there's a picture of the SARS-CoV-2 virus, and I can show you these are the spike proteins on its envelope, outer envelope. Now, ACE2 is a kind of protein that is present in abundance on the surface of the lungs. Now, these spike proteins, they bind very tightly to these receptors, the protein receptors on the lungs. And this allows the entry of these coronaviruses inside the lungs, causing pneumonia and then causing ARDS. And obviously, this may be a severe condition. Now, soon it was also recognized that these S2, in fact, help in converting angiotensin 2. Some of you may know that angiotensin 2 is a very powerful vasoconstrictor, and it has got a deleterious effect on the cardiovascular system as a whole. But ACE2 thankfully converts these angiotensin 2 to angiotensin 1 to 7. Angiotensin 1 to 7 is actually beneficial on the cardiovascular system because of its vasodilatory property, because of its anti-fibrotic property, because of its anti-proliferative property. So obviously it is going to be beneficial on the cardiovascular system as a whole. And then it was soon recognized that yes, the ACE inhibitor and angiotensin 2 receptor blockers are not harmful, but they are safe and they should be continued in these patients. Very soon, position statement paper came out from that was released from by European Society of Cardiology, and this was soon followed by American College Cardiology, American Heart Association, Heart Failure Society of America, who gave a very similar recommendation that patients who were on RAS inhibitors, they should be continued if they were in stable condition. Now, hydroxychloroquine, you may have heard, this is the most controversial and the most politicized molecule in the COVID-19 pandemic. Hydroxychloroquine or chloroquine, some of you may know, has been used for decades altogether for malaria treatment and also for its prophylaxis. It is also used in rheumatoid arthritis and SLE. Azithromycin is a macrolide antibiotic that has shown some benefit in Ebola virus and Zika virus. Now, this has been promoted, this has been publicized, and this has also been politicized in the COVID-19 treatment. And many patients actually started to take, and there were some confusing statements, there were small trials that showed that this was beneficial, and so on. But it soon came to light that it can, in fact, cause harm to patients. And why it causes harm to patient is because of its cardiac toxicity. So let me explain in this slide as to how it can cause cardiac toxicity and why it can be harmful for patients. Now again, just let me explain that this will be harmful more in patients who already have underlying cardiac disease, who already have suffered ischemic heart disease, who has got an inflammatory cardiac condition like myocarditis. Now, if these patients are given a drug like hydroxychloroquine or azithromycin alone, or in combination particularly, then the problem is going to be much more. On this slide, what I'm going to show here is QT interval. So what is QT interval? QT interval is the beginning of the Q wave to the end of the T wave. So this is the QT interval. Now what we are interested in, not the QT interval, but in fact, for all clinical importance, it is the corrected QT interval, which is the adjusted interval based on the heart rate. Some of the patient may be bradycardic, may be tachycardic. So these QT intervals may vary. So depending on the heart rate, you've got to use the adjusted QT interval. Now this QT interval may prolong with the use of these two drugs, hydroxychloroquine and azithromycin. And this prolongation is likely to be much more if they two are combined together. So what is the normal QT interval? So normal QT interval in male is 440 milliseconds and in female it is 460 milliseconds. Now if this QT interval prolongs beyond 500 milliseconds, then obviously it poses a threat to cause what we call the torsade point or a polymorphic ventricular tachycardia. Now these polymorphic ventricular tachycardia, they are a kind of malignant arrhythmia that this can lead to ventricular fibrillation and can cause sudden cardiac arrest and sudden cardiac death. So that is the problem we must recognize, and we must not use these drugs in patients who have already got myocarditis, who have got underlying condition. Now, when it comes to cardiac management, so cardiac management is we do not have much to offer to patients of COVID-19. So the management is largely supportive treatment. And as I mentioned earlier, this is a prothrombotic conditions. Obviously, there's a lot of thrombosis going around, microvascular thrombosis and macrovascular thrombosis. So largely, the management relies on using anticoagulants. Now, these anticoagulants are best used in injectable forms, both as subcutaneous heparin or intra uh, the, the normal molecule heparin or unfractionated heparin. Now, people have also used the DOACs direct oral anticoagulants. Now, the problem with the DOACs is that it can have interaction with some antiviral drugs that are being used for COVID-19. Now, patients who are on RAS inhibitors, which include the ACE inhibitor and angiotensin 2 receptor blocker, they should be continued and should not be stopped, as I said earlier, if the patients are stable enough to take these medications. Arrhythmia is a very common problem, and as you know, a sick patient of COVID-19 will have a lot of electrolyte imbalance. There will be biochemical changes, there will be hypoxia, there will be electrolyte imbalance, and so on. If the patients are in particular in the intensive care unit setting or coronary care unit setting, then obviously they are on inotropes, and these can also precipitate arrhythmia. And these arrhythmia can be as simple as atrial ectopics, ventricular ectopics, but they can, on the other hand, have ventricular tachycardia, ventricular fibrillation. These are the malignant arrhythmia that can in fact lead to cardiac arrest and cardiac death. So these patients should be monitored very closely for malignant arrhythmia, and they should be treated adequately. So what is the treatment for arrhythmia in these patients? Primarily, you've got to correct the underlying cause. Yes, you've got to correct the underlying cause. And there are not many medications that have been studied to how you treat arrhythmia, but few like amiodarone and so on have been used in some patients. But the main thing you need to remember that correct the underlying factors. Patients may become sick, they may have cardiopulmonary collapse, cardiovascular instability. So these patients are initially managed with non-invasive ventilation. With that fails, then these patients are considered for invasive ventilation. And if it is deemed that the patients may not benefit even from invasive ventilation, then there will be a proportion of patients who would meet the criteria to use or be referred for ECMO. So ECMO is extracorporeal membrane oxygen therapy. I'm not going to go in the detail because of lack of time here, but this is one of the modalities of treatment that can be helped for patients who are not oxygenating well despite using the ventilation. So this is extracorporeal membrane oxygen therapy. And some patients who have got a cardiovascular collapse and they are not benefiting from inotropes, then these patients may be considered for intra-aortic balloon pump. The management strategies of acute cardiomyopathy or heart failure per se has again changed during this COVID-19 pandemic. And there are now several guidelines from different societies as to how these patients are going to be managed. Non-ST segment elevated MI, acute coronary syndrome, only if they are high risk or very high risk, and these are the features as you can see here on the slide, high risk features and very high risk features for acute coronary syndrome, non-ST segment elevated MI patients. If they have got these high and very high risk features, only then they are supposed to be considered for invasive management. Rest of the patients should be managed conservatively. Now, when it comes to management of ST segment elevated MI patients, now this strategy during this COVID-19 as to how they are managed has also changed. Now, if you have a facility of offering a cath lab where you have facility for primary PCI 24/7, then if these patients suffer from ST segment elevated MI, you may offer them PCI in your hospital. But if you do not have facility, but you can, or if you have a means to transfer these patients across to another facility who can offer the primary PCI, and if you can do it within a stipulated time and allowing only 60 minutes extra for this COVID pandemic delay, because there has got to be arrangement made to prevent the prevention infection to both parties. And if you can do that, then yes, these patients may be transferred to another facility. But apart from that, these two indication, the rest of the patients, they have got to be treated by thrombolytic therapy. Yes, not by primary PCI, but here you have got to use your old method of treating thrombolytic therapy. Now I know that the new generation, they have not seen, they have never used thrombolytic therapy. Now it is again will be a learning curve for the my young colleagues who have not given thrombolytic therapy, and COVID-19 is teaching us again to go back and learn how thrombolytic therapy is to be given to these ST segment elevated MI patients. So the key learning points, as I've already mentioned, that yes, cardiovascular system is involved. And if it is involved in COVID-19 patients, it increases the mortality, and it can also be a cause for sudden death. And in particular, as I said, that sudden death can also occur in young and healthy individuals because of cardiovascular involvement. The pathophysiology, as I have discussed, is multifactorial and it is also complex. But we have got to know as to how in different ways the heart can be involved due to COVID-19. There's not much of treatment from cardiovascular aspect that can be offered to COVID-19 patients once the heart is involved, but primarily the management or the cardiovascular aspect of the management is mainly supportive. Now, we all know that indeed COVID-19 has brought about a significant change as to how cardiology is practiced during this COVID-19 pandemic. So with that, I thank you very much for your patient listening. I hope you liked my talk and you gained and you would take some key learning points and some information from this talk. And thank you very much for your patient listening.